can fail anytime, and there's nothing as good as having that feel when you're putting a screw in. Now, part of the preparation when going into doing a pedicle screw is to really know the anatomy of the segment that you're fixing, and then of course know the anatomy of the patient that you're fixing, and also know the techniques and bailout procedures. So as you can see, the thoracic spine and the lumbar spine is very, very different, and so they have different insertion techniques as well. Now, just to tell you, basically the pedicle is nothing but a tubular section of bone. Okay, and it's kind of funnel shaped. You've got cancellous at the top end, is where what you're seeing over here. Sorry, is what you're seeing over here. It's kind of cancellous over there, and then it's got a thick bony margins, thicker medially as compared to laterally, and then a large receptacle of bone into which once you cross the isthmus, you've got a lot of bone there to hold on to. What is really important to note is when you're trying to put long screws, is the anterior part over here is concave, and this as well is also concave. So when you're putting a screw in, and if your screw is too long, imagining that this is the front, you put in a long screw, you may actually be out over here. So you really need to be careful when you're putting in long screws. Keep in mind that it's concave anteriorly. The lumbar pedicle anatomy, well, we know the critical diameter is the width, not the height, because the height is always more than the width. And the second critical thing that we need to know is about the angulation, the transverse angulation. It changes from about straight ahead at L1 to about 30 degrees of convergence in the sacral, in the S1 screw. Okay, what are the structures we need to know about? Well, we know about the pedicle. What are the structures we can injure? Well, when you look at it on the medial aspect, okay, you've got the root over there, which is tightly hugging the medial aspect of the pedicle. And when you look at it in the sagittal plane, that's the foramen there, and you've got your nerve root there. So you can't afford to err going medially as well as inferiorly. Now, that does not mean that you can go laterally, because there you can as well injure structures. Now, I've put this up here, to show axial cross sections at L2, 3, L4, L5, and S1 to know that if you're not careful, yes, laterally we may go into the psoas, but anteriorly we could hit the aorta or the IVC. At L4, we never go bicortical, because you've got the vessels there, they're dividing into the common iliac arteries and veins. L5 you may get away occasionally, but it's again not recommended. S1 is the only place where they recommend penetrating the anterior cortex. But remember, the structure that you can damage when you go laterally is the L5 nerve root. You've got the lumbosacral trunk there. So if you start and go this way, you may end up causing damage. So as I mentioned, you need to study the preoperative imaging. Now, most degenerative cases where the spine is straight or with minimal deformity, you can manage with just your X-rays. But if you're worried in your initial fused cases, you can get a CT scan, you can assess the pedicle morphometry, length of your screws, and also, occasionally pick up pedicle dysplasia, like as seen in this CT over here. So if your forearm is forewarned, they say, and you won't want to try cannulating this pedicle because you're going to cause damage. It makes a lot of sense to get CT scans in your first few cases of scoliosis, because of the rotation of the spine, you know which pedicles can be cannulated, which you can't. And also, it makes sense to write down everything for each level and say, this level, this screw, this length, and I got to be angulated at this level relative to the flow. Now, the first step of putting any pedicle screw, obviously, is to get an adequate exposure. So make sure that you expose, you have to expose the spinous process, the lamina, the pars, your facet joint, and then of course the TP. You don't need to go out to the tips of the TP in your latter cases, but initially, if you're not sure, you can do that. The other very important thing is hemostasis. There's nothing more troublesome as blood coming into your field all the time and obscuring your vision. Important point, don't damage the facet capsule of this joint that you are not going to fuse. So if you're doing a 3-4 and going to fuse that joint, you can damage the 3-4 facet, but don't damage the 2-3, because otherwise you're going to end up with junctional kyphosis in a few years' time. So what are the techniques and the starting points of putting lumbar pedicle screws? You've got many different techniques. The common ones that we describe or use are the Royal Camel technique, the Megrel, and the mammillary process technique. Okay? So what is the Royal Camel technique? So the Royal Camel technique was you draw a line bisecting your facet, the mid-facet line, and one going to the TP, and the intersection point was where you put your screw in. And if you had to mark it on a spine model, that's what it would look like. Okay, the second technique was the Megrel's technique, where he said you draw a line along the lateral border of the superior articular process and one along the mid of the TP, and then you'd end up with a starting point which is about here. Now you can use the Roy Camel technique when you're fusing that particular joint, but in the joint above which you're not fusing, it makes a lot of sense to use the Megrel's technique because you don't damage that facet. Obviously, if you're starting more centrally, your trajectory is straight ahead. If you use the Megal's technique, your trajectory is going to be a little more angulated than normal. And this is where it shows. That's the straight ahead in your Roy Camel because you're starting there. And this is, and that is where you have your Megal's technique, which is a little more angulated. The next step, obviously, is once you've decided your starting point, is you decorticate the posterior cortex. You see what is called a pedicle blush, and that shows you this nice cancellous bone over there. You need to use a pedicle probe to find your pedicle. You can use there are the straight ones and the curved ones. In the lumbar spine, I recommend using the straight one. You got sharp and blunt tipped one. There's no real recommendation, no need to use a sharp tipped one because if you have a sharp tipped one and you're pushing, you can easily perforate the pedicle. Use the blunt tip probe because if you're in the right place, it's just going to guide you in very well and the chances of you perforating the pedicle are very minimal. Once you've decided your starting point, then the next thing is your trajectory. Well, obviously a lot of it depends on your patient positioning. You position with a lot of lordosis, your whole spine is going to change. Obviously in scoliosis, things change. Okay, and it's not about, quite often I hear people saying, just go perpendicular. No, it's not perpendicular to the floor because like I said, your positioning and the rotation of the spine makes a big difference. So when we're looking at the mediolateral direction, like we said, it's between 0 and 30 degrees as you come down the lumbar spine. So what is our reference point? Our reference point is going to be the spinous process, assuming that we have placed our patient, properly and there's no scoliotic deformity. And even if there's a scoliotic deformity, it's your spinous process that kind of gives you a pretty good idea as to how to direct it mediolaterally. But what about cephalocaudal? Again, I said it's not perpendicular to the floor. What you have to look at is your TP and your lamina. So it's your TP which is really going to tell you, and that's why exposing your TP, at least the base of it, will give you a rough idea as to how you go cephalocaudal. Okay? Then of course, how do we go? Do we just go anywhere into the bone or is it better to go parallel to the end plate? Definitely better to go parallel to the end plate because you've got good strong end plate cortical bone over there and you get a better purchase. How do you do your movements when you're using a pedicle probe? It's always a two-hand technique. So you've got the head in your right hand, assuming you're right-handed, and your other hand is sort of holding on to the stem of it. And one hand is sort of giving a forward force and the other one is sort of literally pulling it back. Why? Because you don't want to suddenly slip, right? Because if you suddenly slip, you can cause damage. At least here, if you realize something's wrong, your other hand is going to sort of really think. And the other one is also stabilizing when it's on the patient. Okay, it's a rotary movement. You're essentially trying to core the pedicle out. You're not trying to ram it in there. You're just trying to core it. And you'll realize that as long as you're in the pedicle, it will just very gradually go in. If you have a sudden give, almost always there's something wrong. Very rarely are you going to be in the pedicle. The other thing is your paraspinal muscles always try to tend to push your probe straighter. So try, you have to do that, especially lower down, to sort of keep it a little medially directed. Not over, but just keep that in mind as well. Fine, so now you have gone in, you have cored, you have found your pedicle tract. What do you look at now? So you need to look at what's coming out of your pedicle tract. You definitely don't want CSF. Okay, you should normally be getting some blood mixed with some fat globules. That's the ideal. You don't want it gushing out. Yes, in osteoporotic bone, you can have a lot of blood coming out quickly. But if you're getting blood flowing out really quickly, you've probably hit an epidural vein and probably gone a little medial. What do? Now I'm trying to cannulate, I've hit a dead end. Don't mallet it in unless you know it's a really sclerosed pedicle. Get your fluoroscope in and check the directions and make adjustments. You obviously need to just change the direction a little bit. Now quite often we use fluoroscope. Now it makes sense to say using a fluoroscope should guide you in. But a fluoroscope can at times, still not give you the right information. So like I said, there's nothing as that feel that you get when putting the pedicle screw. But yes, if you're putting a pedicle screw in, either minimally invasive, which is where this is more useful, but otherwise in an open technique, when you start off on the lateral, so assuming you're putting a left side pedicle screw, you start at around 11. On the right side, you start at 1. So when you place your tip of your probe there, you should not have crossed the pedicle, or rather you should just be at the entrance to your pedicle. By the time you reach the middle of your pedicle, you should be probably halfway down. And by the time you reach the medial, you should have reached the posterior vertebral cortex. Okay, so this is the way you should be looking at it on your fluoroscope. But in contrast, if you are here, then by the time your pedicle probe is here, you have already crossed, then you're most likely to be out laterally. And if you've already seen your tip medially here and you're still at the open mouth of your pedicle, then you're probably, by the time you put your pedicle screw in, you're going to breach the medial cortex. So that's an absolute no when you're using your fluoroscope. You made your pedicle track. The next thing is to probe. Make sure you're feeling all four your walls as well as the anterior ring. Pay attention to the first 10 to 15 millimeters because that's where the neural structures are. Tapping, always under tap by a millimeter, helps to improve your hold. Maintain the same trajectory as where you felt. Okay, and then recheck the walls of your pedicle again. Now what happens sometimes, you put in a screw, you're not very happy, you redirect it again. So when you're tapping at that time, it's very easy to go into your old track. So what is sort of preferable to do is take your smallest tap, make sure you go into the new hole that you wanted, and then slowly build it up with your thicker taps. And then of course measure your screw. The minimum is about 70 to 80% of the length of your vertebral body. When inserting your screw, don't wobble your hand. Make sure it's the same trajectory that you're going in. So what I like to do is leave my ball probe in there till I get the screw from my sister and then take it out so that I know exactly what trajectory. If your trajectory is changing when you're putting your screw in, again, something's going wrong. Now the last thing we want to end up is with a medial breach like this, because you're going to have damaged your traversing root there. And as I mentioned, you don't want to be lateral as well, because when you're lateral out here, what you're seeing is the exited nerve root over here. And so your patient, you've done a 4-5 fusion, and your patient's going to come back with severe 4 radiculopathy if you breach your 5 pedicle laterally. Okay, so we'd always tend to believe nothing happens when you go laterally, but yes, it can cause a problem. Improving your pull-out strength, we'll talk about that a little later. Coming to your S1 pedicle screws, well, the starting point over there is 1 mm, just sort of inferior or just lateral to your superior articular process. There are 2 different directions that you can go. One is the recommended to go laterally into your sacral ala over there, and well, the hold is not great. You can't go bicortical because you'll go into your SI joint. The better recommended is to go medially, as is seen here, and so that way you're able to get a bicortical purchase, because there's nothing really important or no major vessel actually right in front of your S1 promontory. So what you're trying to do is go there, and your cephalocaudal direction is parallel to the S1 end plate. So when you make your pedicle probe, when you put in your pedicle probe, this is going to be the angulation. See, almost around 30 degrees to the midline, and always try and come out of the promontory here and make sure that you get a bicortical purchase. Now once you've made your entry point up to there and you hit the promontory, how do you proceed from there? Different people use different techniques. Some like to use a drill when they drill the cortex. Some like to use a sharp awl. I don't recommend that you actually try and mallet it in, okay? Because what can happen is that you can actually break the anterior cortex. And if it's sclerotic bone and you're hitting a lot, you can actually cause microfractures. And there are case reports where, the pedicles can actually break, okay? The last thing to do is once you've breached your anterior cortex, always tap it, okay? You need not use the biggest tap, at least use the smallest tap. Why? Because you want to create a thread over there for your screw to go in. Because what happens is you generally use a 6.5 or some use a 7 mm screw in the sacrum. So when your screw goes in and hits the anterior cortex, if there's no thread for it to catch, it tends to sort of wobble over there, and then your screw ends up getting loose. So that's another thing that you do want to be doing. So this is an example where you can see where you really caught the anterior promontory in a perfect sort of a manner. Like I said, when you're it's a large pedicle there, very difficult to really miss it. But you need to be aware, if you're getting bicortical purchase in an adult patient less than 30 millimeters, you have probably, you've probably gone straight ahead. And as I mentioned, this is what you're going to hit if you go straight ahead. So you need to make sure that you are going medially if you want to get a bicortical purchase. What are the pitfalls and cautions that you need to do when you're putting in a lumbar pedicle screw? Quite often in degenerative spine, you'll have hypertrophy of the facet, as can be seen here, and you'll get this little bone. And that can actually distract you from where exactly your superior articular process is. So it becomes important that you sort of knock that off and take that off and actually identify. Anyway, you're going to fuse the joint. Make sure you really see the proper margin, not the hypertrophied bit of your superior articular process, but the real part of it, and then use that as your starting point. Like I said, don't damage the non-fused joint. Try not to use the suction at your pedicle screw, because what happens is you're sucking out this cancellous bone. You're going to lose a lot of blood. All you need to do is put your finger on it when the sister's giving you different instruments, or use bone wax if you're the type who makes all your tracts and then puts in the screws. You can otherwise lose a lot of blood. Sometimes you tend to get stuck when you have a high-grade listhesis, difficult to really find, the pedicle. Makes sense. Do your decompression and then put in your screw. You can really feel the medial and the inferior border and get it in much better. Coming to the thoracic pedicle screws, well, from this image, it's pretty obvious that there are major differences between the thoracic and the lumbar pedicle. The transverse processes are going up and they're pretty bulky as compared to this. You've got your facet joints which are oriented differently. Another very important point is when you look at your pedicle, you can see the pedicle is almost at 90 degrees to the vertebral body. But when you look at the thoracic, you can see it's sort of angulated. And this is what I think they were trying to show previously in terms of the starting point, whether you start here and go that way, or whether you just go in the straight ahead technique. We'll talk about that later. Again, the diameters that you have to know, you have to look at the diameters of the pedicles, the transverse diameter more than the height, the transverse angulation and the sagittal pedicle angulation. Now all this is pretty well documented, and you can see, these things are available everywhere. When you come from T1 to T3, the average is about 5 to 6 millimeters. T4 to T9, the pedicles actually decrease in size. And also your interpedicular distance is narrowest at 4. So you need to be really really careful when you're putting in screws at T3, T4, T5, because your margin for error is a little less over there. And as you come down to T10 to T12, again the pedicles become big. Most people put in 5.5 to 6.5 screws, probably at T12 and maybe even at L1. And your medial lateral direction, it's about 30 degrees at 1. It comes down to around 13 degrees at 3. And then between 13 and 7 degrees up to T9. T11, 12, it's almost becomes straight again. Actually at T12 it diverges a little bit. Okay, and there was a good study done by Datar et al. And they have found that these measurements, please remember again, the medial cortex is thicker. The lateral and anterior cortex is thin and it's very easy to breach out. Okay, so you need to be careful because there are a lot of things that can go wrong in the thoracic spine when you do that. So what are the structures we can damage in the thoracic spine? Okay, on the right side, where now this is like a MRI, so this is the left and this is the right. So on the right side you've got the esophagus at between T4 and T10. You've got the azygous vein, the thoracic duct, okay, on the right side. And when you go down to the left side, you can find that you've got the aorta and also part of the esophagus between T4 and T10. When you're at T11 and T12, you've also got the inferior vena cava. What have you got on the lateral aspects? Well, you've got the pleura and the lung on both sides, and also you've got the sympathetic chain. So that, and also the segmental vessels. So we need to be careful of damaging these things. So our margin for error is definitely lesser in the thoracic spine as compared to the lumbar spine. The steps to insert, well, exposure, you need to see the TP, the SAP and the lamina. Your starting point is variable, like we described that. Optional is when you're fusing joints. If you're not really sure where your superior articular process, you can osteotomize part of the inferior articular process, and that's going to show you exactly where your starting point is. Now this is a rather confusing thing. You need to know it over time, it just becomes part of you. But this really tells you the cephalocaudal direction, the mediolateral direction, and also your starting points. But essentially, to amalgamate all that, there are 3 starting points that we need to look at. One is in what we call the anatomic starting point. When we put an anatomical screw, then of course you've got the straight ahead screw. Both of them essentially start in the same spot when you look at it on this image. But when you look at it from behind, your anatomic screw starts a little higher than as compared to your straight ahead screw. Okay, and I'll show that to you via the next image. And the last, of course, is your in-out-in screw, where you start really far out here. You go in and between your rib and your pedicle, and then get into the vertebral body. Your starting points, again, given there, like I said, your mediolateral starting point is where you take your SAP, whereas your starting point in the cephalocaudal depends on which level you're instrumenting. In the upper thoracic spine, you're going mid-TP. And why is that? Because if you look at your T3 over here, see your pedicle relative to your body. So you need to be going mid-TP to be in the pedicle. But when you're going in your lower thoracic, you need to be, slightly lower here because your pedicle is at a different level. Okay, the steps, again, you use your burr, do a burr out the posterior cortex, and then depending on what you've decided, either a straight ahead technique or your anatomical technique, use your probe again. The mediolateral we have discussed, the cephalocaudal again. The cephalocaudal direction will depend on whether you're putting a straightforward or an anatomical screw. And this is what it really looks like. So when you talk about an anatomical screw, that is, you're going in the anatomic direction of your pedicle. So your starting point is a little higher. So you may need to osteotomize the inferior articular process to let you see this. And then you go straight in there. Whereas your straight ahead screw is this. And this is what it looks like on a C-arm image. And you get a much better purchase, and biomechanical studies have shown that that is better. We have already seen these we've already seen this. by Dr. Abe's demonstration. Now, sometimes when we have a kyphotic spine, it may be a little difficult for us to realize how much of cephalocaudal. So, the patient sort of lying like this. If your spine is this way, your direction would be here. If it's this way, your direction is going to be there. So you can use a Langenback, a 90-degree Langenback, and sort of place it there. And I've just taken a fluoroscopic image just to show you that if you place it on the lamina as seen here, that sort of tells you exactly the direction. Now, not so much in this kind of a case, just for a demonstration, but when you have a significant kyphosis or a scoliosis with kyphosis, this is the sort of thing that can help you to decide your cephalocaudal direction. Sorry. Now, probing of the pedicle, there are two main techniques that have been described. One is the gear shift technique, which was described by Lenke, the funnel technique by Robert Gaines, and then of course the laminotomy technique, where you do a laminotomy, feel the walls of the pedicle, and go in and put your screw in. Okay, that takes away the possibility of, reduces your fusion bed, and it takes away the possibility of wires or hooks in case you need one as a bailout. Now, your gear shift technique, essentially, you need to use a gear shift probe, basically the Lenke's probe, which is curved. Okay, and what you do is you start off once by directing your probe laterally. So you go in for about 15 to 20 millimeters to cross the pedicle. And once you've crossed the pedicle, then you can turn your probe around and it will just direct you right inside. Okay, and that's how you do it. The funnel technique was one of the initial techniques developed, and it's really good, especially in your first few screws, or even if you're going to do your upper thoracic screws and you're not really sure, you're worried because it's not something that we do very often. So what it requires you to do is essentially make a cortical breach over here, probably about 6 to 10 millimeters, okay, and then using a curette or some instrument, you start coring out the cancellous bone. And as you realize, as you're coring out, you're going to see the cortical bone of your TP sort of, if you're putting this is your TP like this, and you're making a hole here, you'll start to see cortical bone here, and a little bit of this here. And as you start coring out, you'll find a nice sort of a soft cancellous area, and that's going to tell you that's where your pedicle is. Then you use your gear shift technique and go in and put it. Okay? The rest of it is the same. You check the integrity, you tag, check integrity again, and put your screw in. Now, the in-out-in technique is one of the techniques. Now, it's a salvage technique. It's not something that we routinely use to put in pedicle screws because, it's very difficult to marry that screw into the rod when all your screws are in one line and this is out. But essentially what it does is, it's used quite commonly in scoliosis, and like I said, a salvage technique. So you start off there, you use that sort of, you feel that you're going out, you use this bone in the rib, bar, pedicle, and then get back into the vertebral body again. So, tips, pitfalls, and cautions. Well, always start from, if you're doing a scoliosis or even if it's a minimal deformity, start from a neutrally rotated vertebra, and preferably distal, where you've got a wider pedicle. Start from something easy, and then you can develop a harmonious relationship of your pedicle screws. The anterior and lateral vertebral cortexes in the thoracic spine are not strong, easily perforated out, and it can cause major injuries. There have been reports of patients developing cardiac tamponade when people have put in thoracic pedicle screws, and I'm talking about people with significant amount of experience. It can happen to any one of us. Okay, the pedicles at T1, T2, and T3, they are more widespread, okay, as compared to the other pedicles. So what tends to happen is you'll see that your pedicle screws are sort of far much wider as compared to when you're down here, and actually, looks like a funnel when you put your rods in. So you need to try and keep that in mind when you're putting your screws in as well. Well, what do I do when I get a pedicle breach? Well, the first thing is not to panic. If you do a lot of pedicle screws, you'll know, well, that's not going to be your first one, you're going to have more. First thing is try and understand where is your pedicle breach, and then try and retract and try and redirect it. Okay, change from a straight ahead technique to an anatomical technique, or you can sort of direct it more medially if you've gone out laterally. Generally, what I tend to do is if I'm putting many screws in and I have a difficulty with one screw I perforate, I just seal it off with bone wax, go put my other screws, do my decompression, and then feel the walls of my pedicle, because you just get 1 second chance, and then put your screw in. And the chances of you missing then are very minimal. How do we increase the safety? Well, you've got the PediGuard, which can give you some sort of feedback. You've got navigation and IOM, but nothing as good as learning to put these freehand and then managing it with the others. So, well, just to summarize, we need to know the normal pedicle anatomy of the segment we are fusing, and also the anatomy of which is peculiar to our patient. Just need to follow standard points of entry and trajectories. We need to know different techniques and bailout procedures. And the most important thing is gentle coring of the pedicle. Okay, that will lead you in. Do not force it in. Okay, it doesn't work like that. Thanks.